Hello everyone. In this class, we'll try to learn about coronary circulation. The learning objectives are to give the normal values of coronary blood flow, name the coronary arteries and the parts of heart supplied by the coronaries, list the special features of coronary circulation, name the methods of measurement of coronary blood flow and give their basic principles of measurement. Understand the regulatory mechanism of coronary circulation. Appreciate the importance of physical factors in the regulation of coronary blood flow. Know the basic pathophysiology of myocardial infarction and describe ECG changes in acute myocardial infarction and the physiological basis of treatment of acute myocardial infarction. Coronary blood flow is about 4.7% of the total cardiac output. Stoppage of heart functions for more than a couple of minutes is life threatening. Therefore, it is essential to maintain an uninterrupted and adequate blood supply to the heart. Hence, coronary circulation is a special circulation in the body. Coming to the coronary blood flow, it is supplied by the right coronary artery and the left coronary artery. The right coronary artery supplies the right ventricle and the right atrium, whereas left coronary artery supplies the left ventricle and left atrium. There are no anastomosis between the right and left coronary arteries, thus the coronary arteries are end arteries as their territories of blood supply by these arteries do not overlap. The sinuses of Valsalva is present in behind the semilunar walls where the eddy current develop, which keep the wall leaflets away from the wall of the vessels during systole. The cusps float in the blood between the wall in their closing positions. This allows the blood to enter into the coronary arteries. So this diagram shows the blood supply to the heart. It is mainly by the right coronary artery and the left coronary artery. And the left coronary gives a circumflux artery, and another branch continues as the anterior interventricular artery, which is going to anastomose with the right coronary artery. The major system consists of coronary sinus and the anterior cardiac veins that drain into the right atrium. The minor system consists of arteriosinusoidal vessels that drain from the arterioles to cardiac chambers, thespian veins that drain from the capillaries to cardiac chambers, and arterioluminal vessels that directly drain from coronary arteries to the heart chambers. The blood is innervated by the sympathetic nerves, and sympathetic stimulation causes coronary vasodilatation as coronary arteries are rich in uh, beta receptors. Parasympathetic stimulation causes vasodilatation, which is mediated via cholinergic receptors. Some of the special features of coronary circulation: coronary blood flow decreases during systole and increases during systole. The cardiac blood vessels are compressed during systole, resulting in decreased blood flow to the myocardium. This vasocompression effect is maximally observed in subendocardial layers. During systole, relaxation of the cardiac muscle increases the coronary blood flow. The coronary arteries are the end arteries. Therefore, blockage of the coronary arteries results in ischemia and infarction. The coronary blood flow is adjusted according to the metabolic need of the myocardium. Coronary blood flow can be increased about 4 to 5 folds to meet the heart's more oxygen need during exercise. Thus, there is adequate coronary blood flow reserve. The heart utilizes wide varieties of substrate for its metabolism. These include free fatty acids, glucose, pyruvate, lactate, ketone bodies, and amino acids. But the major source, about one-third of the energy supply, is free fatty acids. Heart muscles extracts about 80% of the oxygen from the arterial blood. Thus, artery-venous oxygen difference is very high in heart even at rest. Therefore, major method to increase oxygen supply to the heart as required during exercise is to increase coronary blood flow. Coronary blood flow. The heart weighs about 300 grams. The blood flow to the heart is approximately 200 ml per minute, which is about 85 ml per 100 gram of the cardiac tissue per minute. The rate of coronary blood flow is the second highest in the body next to the renal blood flow, which is around 420 ml per 100 gram of the tissue per minute. The coronary blood flow constitutes about 4.7% of the total cardiac output. However, the rate of oxygen consumption of heart is highest of all the organs in the body, which is around 9.7 ml per minute per 100 gram of tissue per minute. Measurement of coronary blood flow. Coronary blood flow is measured by direct method and indirect methods. Direct method. The coronary blood flow can be measured directly by placing electromagnetic flow meter in the coronary artery. This is used in experimental animals and in human undergoing open heart surgery. The indirect method are fixed method and radionuclide method. In fixed principle or fixed method, the subject inhales a mixture of air and an inert gas like nitrous oxide uh, till the gas is distributed in the tissue according to the partition coefficient. Then the arterial blood and venous samples. The arterial blood is collected from peripheral artery and the venous sample collected from the coronary sinus. The coronary blood flow is calculated as the ratio of the amount of inert gas passing through the coronary arteries in a unit time to the average uh, of artery venous gas concentration difference. So hence blood flow is equal to amount of inert gas taken up per minute divided by artery venous difference of the gas. Radionuclide method. A radionuclide substance like thallium is injected intravenously. The gamma camera is placed on the chest to monitor the thallium uptake by the heart. Radioactive xenon can also be used for this purpose. By this method, difference in the blood supply through the individual arteries to different parts of the artery can be measured. Coming to the regulation of the coronary blood flow. Important is the neural regulation and metabolic regulation and the physical factors. Neural regulation, either sympathetic or parasympathetic fibers. Sympathetic control. Sympathetic stimulation produces vasodilatation due to the predominance of beta receptors in the coronary vessels. Stimulation of beta receptors results in vasodilatation. Vasodilatation also occurs partly due to the deposition of the metabolites in the sympathetic stimulation, as a sympathetic stimulation accelerates the cardiac activity that increases the myocardial metabolism. Parasympathetic control. Parasympathetic stimulation causes vasodilatation, but there is a sparse sympathetic innervation to the coronary blood vessels. Metabolic regulation. Metabolic regulation of the blood flow is well developed in the heart. A close relationship exists between the coronary blood flow and the oxygen consumption of the myocardium. Metabolic factors that cause coronary vasodilatation are hypoxia, increased local concentration of carbon dioxide, increased hydrogen and potassium ion concentration, accumulation of the lactate, adenosine and adenine nucleotide, and increased release of prostaglandins locally. Adenosine mediates reactive hyperemia of the ventricular muscle. Another important factor is autoregulation. An autoregulatory mechanism maintains the normal blood flow within the pressure range of 70 to 110 mm of Hg. However, the autoregulation of the blood flow in the heart is not so well developed like it is in the brain. Then physical factors. The blood flow to the cardiac muscle is dependent on the myocardial tension, the pressure that builds up in the muscle during contraction. It is the primary factor in the determining of the coronary perfusion. The vasocompression during myocardial contraction decreases the coronary blood flow. Coronary blood flow increases during diastole. This diagram shows how the coronary blood flow increases in the left coronary artery and the left coronary artery during the systole, especially in the diastole. In the systole, the LCA, the left coronary artery and left coronary artery blood flow is going to decrease, especially in the left coronary artery. It is going to increase during diastole. Coronary artery disease. Decreased blood flow to the heart leads to myocardial ischemia, that is angina pectoris, and if severe and prolonged results, severe and prolonged uh, reduced perfusion results in myocardial infarction. It usually occurs due to the coronary atherosclerosis. Usually, the disease starts with angina, and infarction occurs when obstruction occupies at least 75% of the lumen of the coronary artery. Some of the known risk factors for coronary artery disease are age more than 40, males, family history of coronary artery disease, smoking, hypertension, hypercholesterolemia, diabetes, and some of the hemostatic factors. Then reduced physical activity, obesity, alcohol intake, hypercholesterolemia, or hyperhomocystinemia, stress. These are some of the risk factors for coronary artery disease. Angina pectoris refers to the chest pain due to the ischemia of the cardiac muscle. The pain is usually felt in the chest below the sternum towards the left side. The cause of pain in myocardial ischemia is due to the decreased blood supply, which results in accumulation of the P factor in the ischemic tissue. The pain is typically radiates to the ulnar border of the left hand, but can also radiate to back or even neck or to the abdomen. Myocardial infarction occurs when ischemia is prolonged, following more than 75% of obstruction of the coronary arteries. The factors that precipitate acute myocardial infarction are the spasm of the coronary artery at the site of atherosclerosis, platelet aggregation at the site of obstruction, and hemorrhage due to the atherosclerotic plaques in the coronary artery. Stress is known to induce coronary spasm. Increased circulating levels of lipoprotein A, ultra-sensitive C-reactive protein, oxidized LDL, antiphospholipid antibody, TROP-I, homocysteine are strongly correlated with acute myocardial infarction. Acute myocardial infarction causes severe chest pain that radiates along the ulnar border of the upper arm and hand. The chest pain is usually associated with excessive sweating. Diagnosis of coronary artery disease. Typically, ECG changes in acute infarction uh, are the first change to occur are ST segment elevation in the ECG leads over the infarcted area. The leads placed on the opposite side of the infarction record ST segment depression. There will be change in the enzymes in the plasma. The damaged myocardium releases enzymes into the circulation. Detection of elevated levels of enzymes such as creatinine kinase, lactate dehydrogenase, but most specific is increased concentration of CKMB, isoenzyme of CK, and fraction of LDH. So this is the ECG changes that you see in acute myocardial infarction. That is, you see there is elevation in the ST segment. Typical clinical presentation is severe chest pain associated with excessive sweating with or without radiation to the ulnar border of the left hand. Then it is diagnosed by coronary angiography, which show the details of counters of the coronaries and the site and extent of obstruction in the arteries. So this diagram shows uh, the obstruction in the right as well as right coronary arteries. Then the basis for the treatment of coronary artery disease, medical treatment. Most of the time vasodilators are used, which cause the arterial dilatation that decreases the afterload and cause venodilatation that it decreases the preload, that is venous return. Thus preload and afterload on the ventricle are reduced, that decreases the myocardial oxygen consumption. Streptokinase causes lysis of the intracoronary clot when injected intravenously. It facilitates the conversion of plasminogen to plasmin that causes fibrinolysis. Streptokinase removes the obstruction if injected in the early part of the onset of infarction. Tissue plasminogen activator activates plasmin and causes fibrinolysis at the site of thrombosis, as it activates plasminogen bound to fibrin clot. Coronary angioplasty. Immediately following the confirmation of the diagnosis, a catheter containing a balloon is inserted into the coronary artery. Then the balloon is inflated at the site of obstruction to dilate and constricted the artery. This procedure is called as coronary angioplasty. Calcium channel blockers like verapamil cause coronary vasodilatation, and antiplatelet aggregating agents, that is low dose of aspirin, inhibit cyclooxygenase, which helps in the thromboxane A2 formation. Uh, Thromboxane A2 potentiates the vasoconstriction and platelet aggregation. Thus, aspirin inhibits platelet aggregation. Folic acid and vitamin B12. The increased levels of plasma levels of homocysteine is strongly correlated with myocardial infarction. Homocysteine produces damage to the endothelial cells of the blood vessels that becomes uh, the site for platelet aggregation and facilitates atherosclerosis. Folic acid, vitamin B12 convert homocysteine to methionine, a non-toxic compound. So thus they are going to prevent the, the formation of the plaques. Surgical treatment. The definitive treatment of myocardial infarction is to bypass the block in the artery by implanting a vessel in the heart taken from the other parts of the body, that is, which is called as bypass surgery. So this is also called as coronary artery bypass graft, that is CABG. The grafted artery bypasses the blocked coronary artery. Usually the artery is directly connected from the aorta to the ventricular muscle. Therefore, it is called as aortic CABG. This is in brief about the coronary circulation and some of the applied aspects related to coronary circulation. Thank you.